Good evening, friends and colleagues, and a warm welcome to 53rd edition of the 4D session, which entails a detailed discussion on the intricacies of diabetes. Tonight, we'll discuss on challenges in the primary care for diabetes and hypertension, and we know that hypertension is known as a silent killer. We know it affects the five organs, namely the brain, retina, heart, kidney, and peripheral vessels. And because it affects these vessels, it can cause a sudden death or a death which is inevitable. So, therefore, it is called as a silent killer. Now, we know the prevalence of diabetes and hypertension together is quite common. If you see patients with diabetes, 50% of them will have hypertension. And if we look at the patient of hypertension, 40%, close to 40% of them can have diabetes. So that's very close association because they share many common risk factors. Therefore, this is a very close association, and therefore, treatment of hypertension is equally important, perhaps more important than treatment of blood sugar. That does not mean you underestimate blood sugar, but treatment of hypertension is of immense importance when you take a patient of diabetes in a day-to-day management. Now, in the year 2023, in the month of June this year, we had the latest guidelines of hypertension, which are released by European Society of Hypertension, and this definitely emphasizes the management of comorbid condition in patients of hypertension, and of course, diabetes is one of the important. And to name few, the sleep apnea, the obesity, COPD, migraine, chronic inflammatory disease are many of these factors which are supposed to be important comorbid conditions in patients of treatment of diabetes. Now, to dive deep into this subject, today we have a very brilliant speaker, Dr. Parag Shah. And just to introduce him briefly, he is DM DNB Endocrinology from the SGPGI Lucknow. He's director of Gujarat Endocrine Center, Ahmedabad, and awarded the most inspiring endocrinologist of India by the Economic Times of India. Has done more than 50 publications to his credit, and today he will discuss in a great details about the hypertension and diabetes and how do we approach these patients of hypertension and diabetes. Over to you, sir. The floor is yours.
Thank you, sir, for your kind introduction. It's always a privilege and pleasure to share a dais with you, sir. That diabetes and hypertension coexist quite a good number of the populations, and prevalence of both are increasing rapidly. And we are seeing younger and younger people suffering from diabetes as well as the hypertension. And unfortunately, the morbidity and mortality associated either with the diabetes or with the hypertension, and more commonly because of the both, is occurring at a younger and younger age. So there are lots of huge population who is present in our society. Many of them are taking treatment properly, many of them are not aware about the disease, many of them are not able to accept the fact that they are suffering from the chronic disease like a hypertension or a type 2 diabetics. Many of them fails to accept that they require a lifelong lifestyle modifications, medications, supervision by the doctors as well as from the pathology, and keep their metabolic health in a proper shape. So there are huge challenges in our country, which we all know is a vast country with lots of different type of the populations with a different mindset. It is not just the socio-economical differences or a cultural differences, but there are lots of psychological differences about the chronic diseases. Lots of people have a fear of taking the medications. Specifically, if we talk about the allopathic medications, they consider it that this is habit forming, this might create some problems for me because of the medications. My kidney or my heart can get affected. So there are huge number of challenges. So we'll go one by one. And what are the real challenges in a specifically in a primary care settings, we all sitting at a tertiary or a secondary care centers, we might have a less challenges, but we'll focus, as the title suggests, what are the challenges which primary care doctors or a primary care level physicians or a patient populations faces when we talk about the management of diabetes and hypertension. Next, please. Diabetic prevalence is very rapidly increasing in our country. 1 in 11 adult populations are having diabetes in our country. Almost half of them are not knowing that they are having diabetes, or they may consider that, oh, I had a stress and that's why my sugar was little bit high. I had a COVID 3 years back, that's why my sugar was high. So that are not diagnosed, or they're not really accepted that they are having a type 2 diabetics, and they require a proper management. Proper management may not always means that taking the medications, but lifestyle measure also they have to follow. And we are only second to the China as far as the diabetic population is concerned. We are likely to surpass China as we are surpassing the overall population in a near future. 40 million adults in India have a impaired glucose tolerance, or what we call now is the pre-diabetic, who have a high chance of development of the type 2 diabetes if their lifestyle is not modified to the optimum level. So there is a huge burden of diabetes. There is a bigger problem of a undiagnosed diabetes, and there is a huge challenge that all these pre-diabetics, quite a good number of them, 30 to 40% of them in next 5 to 10 years is likely to develop type 2 diabetes unless their lifestyle is modified quite significantly. So the rise in the number of diabetic populations because of our genetic factors, which was there for centuries together, but there is a sudden change in our lifestyle, sudden improvement in our socio-economical status. We all have become practically sedentary for our day-to-day physical activity. Forget about the physical exercise. We have become sedentary. Schools are having a less time devoted to the sports. Many schools don't have a playgrounds because of the time constraints. Most of the school going children, they don't ride a bicycle. They go by either a van or a auto or a school bus. Canteen foods are commonly consumed. With this food delivery apps being available, even at the day of exam, young people can have the pleasure of having a outside food delivered at home, even at a midnight at 2 o'clock or 3 o'clock when they feel hungry while they are reading. So all these factors together has suddenly increased the population of the type 2 diabetes in our country. Then ultimately that leads to more than 7,705, almost 750,000 deaths caused by diabetes in our country in the couple of years back. So there is a huge mortality as well as the morbidity associated with the diabetes. Next, please. So if you take the similar scenario for the hypertension, as Dr. Nagulkar has mentioned, hypertension can lead to the atherosclerotic cardiovascular disease, LV dysfunction, kidney alternations, vision loss, severe stroke, and there are lots of causative factors which are common among the diabetic as well as the hypertension population. As you age, you are likely to get hypertension. Not so correlation with the age and the risk of development of diabetes. Excess alcohol consumption, central obesity, stress, sedentary lifestyle, salt intake, inactivity, poor dietary habits, increase into the BMR, all this together has a significantly increase in the number of hypertensive population in our country. One third of the urban adult populations are suffering from diabetes. One fourth of the rural populations also is suffering from the hypertension. You can see that all these packet foods are available, which cost 5 to 10 rupees is available. You can corner of the country, wherever you go, you will find a pack of chips or the namkeens available with us. And male, females, again, there is a huge proportion of the patients are having a hypertension in our country. So if you translate that, 29% of the patients are having population is having a hypertension. 1.5 million people are having a diabetes hypertension in the Southeast Asian populations, and 240 million people in India have will be having hypertension by 2025. So just like a diabetic, hypertension also is going to be increased by leaps and bounds. What are the challenges in the primary care of diabetes and hypertension? In spite of excellent medications available for type 2 diabetes as well as hypertension management, why we are facing a challenges. First is the lack of general awareness about diabetes, hypertension, and its related complications. For example, hypertension. Unfortunately, people consider that hypertension would occur whenever I have a stress. So patient comes to us in a OPD, we measure the blood pressure and blood pressure is a 180 and 110. They consider that, no, sir, I don't have a hypertension. Only when I came to you, I have hypertension. Ambulatory blood pressure monitoring is the solution, but practically in a real life scenario, we cannot offer that ABPM to 99.999% of the population. So acceptance about the disease is a big challenge, and then general awareness about the complications of the diabetes and hypertension and dyslipidemia for that matter. All these three are silent unless it affects the major organ by more than 80 to 90% of the organ is damaged. Patients don't have symptoms. If the cough cold increases, if the headache increases, people feel that okay, I need to take a medications, but blood sugar increases, blood pressure increases, lipid increase deteriorates, patient don't have symptoms. So unless they are aware that it is a silent disease, as Dr. Vijay sir has highlighted, unless people accept that this is the silent killer and patients may not have the symptoms, they are not going to be compliant with the medications, consultation, and investigations. In a remote area, again, challenge about the healthcare professionals available with their qualified doctors available there. Many of the times, healthcare providers, they bow down to the patient's wish and the desires. They patient says, let me come after 1 month, let me control my lifestyle better, and then my diabetes and blood pressure would be controlled, and then I will take medication. So this is a again huge challenge about remote areas, trying to convince the patients to take the medications, huge OPD, less time for each patients, where a primary care physician has to see lots of patients with a lots of other ailments also. We as a super specialist, okay, we are focusing on our core strength of say diabetes, hypertension management. There is a economical disparity between urban and the rural settings. So Indian drugs are quite effective and quite cheap, but still some patients may not afford the best possible treatment. And as I mentioned, there is a scarcity of the qualified healthcare personnel, specifically into the periphery. We don't have a good paramedical staffs even in the major metro cities or a tier 1 or tier 2 cities also, who can spend some time and explain the patient, like healthcare nursing staff or an educator who can spend some time and make them understand that okay, why this diabetes and hypertension requires a regular treatment and a regular follow-up with a doctor and a laboratory tests, financial constraints, social barriers. In our country, people consider that other than allopathy, medications have no side effects, and they try to control their disease with the pathies without even trying to whether it is getting their disease under control or not. So all this together leads to inadequate control and a poor adherence to the medications. So that is a unfortunate challenge, predominantly in the primary care settings when we talk about the chronic disease like diabetes and hypertension. Next, please. As I mentioned, because of the lack of time, paramedical staff to support, there is a lack of communication between primary healthcare workers and the patients, lack of resources such as steady supply of the medications, laboratory supplies, free, like government hospitals should have at least creatinine lipids examination to be done, inadequate information system that does not facilitate follow-up and the revisits, like in the example in the USA, if there is a time for refill of your medications, the reminder goes. Here there is no system that patients would be reminded to take the medications and to go for the regular checkup. Poor support for the self-management. People go by the Google, go by the cholesterol is not considered to be important by the so and so organizations from the US, and people start taking the medications stop taking the statin, for example. Doctor center care process that implement the adequate counsel. So there is a huge need of the good counselors available at a private as well as the public healthcare facilities. Next, please. So any chronic disease like a diabetes, hypertension, or a dyslipidemia or obesity, most important is the healthy lifestyle, and being a physically active is the most important. I always tell my patients that everyone should walk. Those who have a legs, God has given us a leg, or nature has given us the legs to walk. No animal, no insects uses any vehicles for travel. They all use their own uh, limbs to travel from one place to another place. So I always tell that everybody should walk. You need only three things to walk. One is the legs, second is the land, and third is the desire. So two things are given by the nature or a god. The determination or a desire to walk should come from within. So we should try to explain to the patients that minimum 150 minutes of the moderate intensity simple exercise like a walking each week, or 75 minutes of a vigorous intensity exercise each week is crucial. People out of enthusiasm goes to the gym for 1 month, 2 months, and then they stop doing everything together. And that's why you have a very attractive scheme for the yearly membership, because they know that 90% are not going to come more than 3 months after they take the 1 year membership, because the motivation does not last for a long period of time. So we have to encourage people that just do a simple brisk walking for 150 minutes in a week. So if suppose somebody takes 5 days a week, only half a minute, that is hardly 5% of our time of the day. I always said that devote at least 5% of the time of the day for your health and for your well-being. We devote so much of time for our routine activity to earn money. If the homemaker is there to cook, to take care of the family, but we don't take 5% out of our 24 hours for our physical activity. Moderate exercise should include like brisk walking and the swimming. People should also consider doing the muscle strengthening exercise, but it is should be on a long term, regular basis, rather than it comes out of the sudden uh, enthusiasm and then some reasons not to exercise, and then there is a huge period where people are not doing any physical activity. Maintain a healthy weight, that is very crucial. Like when I was studying in my medical college days in 80s, one of our senior teacher used to tell at that point of time where probably metabolic syndrome and the central obesity importance was not that much in the medical literature. He used to tell that jitni badi kamar utni kam umar, means ki central obesity would lead to the less life expectancy. I remember during my MBBS days in the clinics, that teacher used to tell that jitni badi kamar utni kam umar. So that is true actually. The central obesity, now we'll know that it's the culprit of all the metabolic disorders like diabetic, hypertension, dyslipidemia, atherosclerosis, and so on and so forth. So even if somebody who is obese loses 3 to 5% of their body weight, it would improve their chronic disease like hypertension and the diabetes. So many times people are obese by 20%, 25%, and 5% weight loss sometimes cosmetically may not be very encouraging for them. Then people get frustrated that I have done diet, exercise, and I lost only 3 kg of weight. I was 90 kg, now I am 86 kg. So I lost only 4 kg of the weight, and they feel dismotivated, and that is the actually the problem, that people have a motivation but they have a undesirable or a unrealistic expectations about their weight loss. It is possible, but more than 10% weight loss is really very difficult. But up to 5% weight loss is easily achievable, and medically 5% weight loss is considered to be medically beneficial, and that why any obesity medications would get approval in the USA if you show the 5% weight loss without any significant side effect, that the drug would be approved for the weight loss purpose. So 5% weight loss cosmetically may not be very appealing or encouraging, but we should tell the patient that whatever weight loss you have gained, you have done is good for your health, and try to maintain whatever you have lost even if you cannot lose further, at least try to maintain at least 5% of your body weight and try to go gradually. The results would be less dramatic after you lose 5% of the weight. People will say that I was doing the same diet exercise and I lost around 3 kg in 3 months. Now, next 3 months, I have done the same diet, same exercise, same lifestyle. I lost only 1 kg of weight. So that is a human tendency, body's own tendency, that body does not allow more than 5% weight loss to be done very easily. More than 10% is really difficult. So patient should not get dismotivated. That is what we should try to emphasize, that any weight loss is good. If you can achieve 5% weight loss, that is medically, metabolically quite helpful. Cosmetically, you may still look obese or overweight, but medically you have benefited. Next, please. For healthy diet, I think younger generation specifically are not eating a, a regular uh, amount of the fresh fruits and the vegetables, which contains a lots of vitamins, minerals, and the fibers. So we should encourage right from the early childhood to have a fresh vegetables and the fresh fruits, not the fruit juices, fresh vegetables and the juices or fresh fruits. Focus on the high fiber foods, including whole grains, limiting added salt and the sugar. Avoid all the packet foods which contains lots of salt and the preservatives, which is medically and metabolically unhealthy. Avoid, limit the unhealthy fats in any form, specifically trans fats. We say to take zero. Minimize the animal fats. People may consider that guy's ghee is very good, so I only eat the guy's ghee. But animal foods in excess is again not good. Tobacco usage in any form is very detrimental to the metabolic health and the vascular health of the people. So tobacco, either to smoking or a chewing tobacco, causes blood vessels to constrict, leads to the more atherosclerosis, leads to temporary increase into the blood pressure, and there will be a plaque formations within the artery, which ultimately may lead to the stroke or the acute myocardial infarctions, and it increase the risk of type 2 diabetes, the heart problem, kidney problem, retinopathy problem, peripheral vascular disease problem, chances of diabetic foot amputations, leg amputations are very high. Those who have a diabetic peripheral neuropathy also get worsens if the patient is a regular tobacco user. Next, please. So, what are the treatment strategy for the diabetic patient? We are talking not about the tertiary care or a secondary care. What minimum we can offer, even at a primary care level, is to give the combination therapy early in a type 2 diabetic management. It is always difficult to increase the number of pill on a subsequent follow-up. So, if you know that one drug is not going to work, which is true actually in 90% of the patients, that one drug even at the diagnosis is not going to work for a long period of time. So you start with the early combination therapy, takes care of the multiple pathophysiology, and which is available as a single pill, not very expensive in our country. And novel drugs like DP4 inhibitors and metformin combination, we all are using quite commonly. And now we got SGLT2 inhibitors also available with us. GLP-1 receptor agonists are good, but primary care setting it is extremely difficult to initiate GLP-1 receptor agonists because of the cost and the lots of side effects of the upper GI side effects. So primary care physicians, I think, can safely use DP4 inhibitor and SGLT2 inhibitors, which acts through the different pathophysiological pathway, which does not lead to hypoglycemia, which does not lead to weight gain. SGLT2 inhibitor, we all know that it leads to the weight loss. When we combine DP4 inhibitor, metformin, and a SGLT2 inhibitor in a single pill or given separately, it significantly reduces the HbA1c, puts beta cell at rest, reduces insulin resistance because of the reduction into the central obesity, reduction into the glucotoxicity. So it is a safe approach that SGLT2 inhibitor, DP4 inhibitor, along with the metformin and a lifestyle modification should be started early in a journey of a type 2 diabetic management.
For a
Yeah.
wonderful lecture. I like your analogy in saying that animals don't need vehicles to walk, but men require vehicles to walk because they don't have desire to walk. There's enough land for the people to walk, and they have limbs to walk. That was a very fantastic analogy. I think I liked it very much. So after
Thank you,
wonderful
sir.
talk, there are many questions. I think we'll answer them one by one. The first question that is to you is to see that there is a lot of malnutrition in the country, And despite of malnutrition, we see higher prevalence of hypertension and diabetes. How do you explain this paradox? That one hand you have malnutrition, the other hand there's increased prevalence of hypertension and diabetes. How do you explain that?
Yeah, actually, malnutrition per se would have be in a different way. Like malnutrition is a total calorie starvation, protein malnutrition. But in general, like somebody who is not very affording, who is not able to have the adequate amount of the food, and he is a generally malnourished, like macro as well as the macronutrients are deficient. In them prevalence is definitely less compared to the those who are having a good socio-economical status, but it still can occur because unfortunately genetically we all are what we call the thin fat Indians. So even though somebody does not look obese or overweight, has a some amount of insulin resistance, and if somebody has a bad genes and there is a sudden change in their lifestyle, the chances of them also getting a diabetes and hypertension is high. It is still less than those who have a good socio-economical status and they have a overnutrition is there. But in general, they have a less chance, but still they can develop hypertension as well as the diabetes. So nobody is immune to not having the diabetes or hypertension or even
Yeah,
dyslipidemia. Many times people feel that I'm thin and lean. How can my lipids be so high? And we see lots of patients who are BMI is 18 or 19 and their LDL is 180, 190. And sometimes people are wondering. So all these are a metabolic problem which gets aggravated from the bad lifestyle.
yeah, I think you're right because we had this ICMR data, which was published on the 6th of June 2023. And what it said that we surveyed almost 28 states and 8 union territories, covering almost 113,000 population. And what was seen that the incidence of diabetes was 11.4%, hypertension was 36%, and a central obesity was 40%, and dyslipidemia, as you mentioned rightly, 81%. So this is the population that we have, which is strongly atherogenic and has a central obesity, which is a basic cause for all these metabolic conditions like dyslipidemia, hypertension, obesity, microalbuminuria, and so on and so forth. Plus, we have the aging population because of the longevity of survival
Longevity.
and the rapid urbanization of the rural areas also now because most of these facilities are available even in rural areas. And as you already mentioned about decreased physical activity and highly processed food which people eat, because Dr. Mishra has presented a paper in which looked at people in Delhi. They're eating absolutely food on the street, which just costs them 10 rupees. And this food is very concentrated in saturated fatty acids, and it is a very cheap kind of food, but it is a very unhealthy food. And because of these reasons, as you also mentioned about Asian Indian phenotype, we have the high prevalence of hypertension and diabetes in our country. Okay, let's look at the westernization of the Indian population. Has it any contribution for the hypertension in India?
Yes, I think see food industry has significantly increased. It is easier to get food packet than to get the medications or even a bottle of water. So any you can corner 5 rupees food, people with a Mercedes or a people on a pulling a cart would afford. So all this processed food, which is very palatable, not perishable, easy to carry, you really enjoy the taste, and lifestyle has suddenly become very sedentary with this internet. I think most of the people their free time they spend on the mobiles or an internet rather than going for a walk. People will say that I don't have a time, but they will spend half an hour or 1 hour or 2 hours on the screen time. Screen time is increasing, and everybody in this country spends at least 2 to 3 hours per day on an average on the different screens, most commonly the mobile. So we have seen the people who have totally westernized, and we have taken the bad habits from the west. We have not taken the good habits. Like in Australia, every weekend they will plan for the some sports activity or going to a beach or swimming or doing some sports activity. In India, Saturday, Sunday, gyms and the walking parks are totally empty. Sunday, practically nobody does any exercise. While we have more time, we should exercise more rather than taking a holiday off. So restaurants are all full. Food delivery apps are there. Even in the tier 2, tier 3 cities also, all these fast food chains franchises are open. So rapid westernization, rapid marketing by this food, so-called healthy food, are not always healthy. Sometimes
Yes.
people say that okay, we only eat the this type of the food which is supposed to be very healthy. Actually, if you see the calories, practically except water, buttermilk, and a lemon juice, everything has a calorie except salad. I think on an average, every food which we consume, 100 grams gives you minimum 350 calories. So people sometimes say I take only the boiled sprouts, but the quantity also is important apart from the quality. So this rapid westernization, all these processed food puts on lots of preservatives to keep them fresh, which all are having a high sodium content in that, and that again would increase the prevalence of hypertension. And of course, you see all the packet food contains the palm oil because it keeps them fresh and the crispy. Apart from being a cheap, you take any packet food, it will have the palm olive, whether any biscuits or any namkins, because that keeps them fresh, crispy, gives the taste, and it is cheaper. So all this together, I think we don't know the n number of the preservatives, colors they use. So all these things together, I think has increased not only the metabolism into the incidence and the prevalence of the different types of the incidence and the prevalence of the different types of the malignancies also has increased significantly. So this
Right.
price we are paying for the rapid westernization.
Yeah, I think you're right. It's urban area, of course, there is because they have all the access to all the modern things. But what is interesting and what is worrying us, even in the tribal areas, there are studies done in the eastern part of India and Nagaland, which we know that all these tribal areas consume less salt. We heard of the Kumamoto communities or those tribal areas, the consumption of salt is very less. And that's why the incidence of hypertension is very less in tribal areas. Now, what's the state in tribal areas today? They have a very high consumption of salt. And 40% of the people in Nagaland have hypertension, which again tells you that even the tribal community also has undergone a metamorphosis, has undergone change in consumption of salt plus tobacco is again additional factor in them, which has caused the increase in hypertension. And they also have now come under the purview of stress. They also now have a stress. We know that there is a lot of the riots in Manipur and all those areas, the tribal areas, and they also a lot of stress. So therefore, the urbanization is not the only affected population, but even the tribal areas are also affected because of hypertension. That's why the incidence in India has come to 36% in the general population, which is pretty high, even above the incidence of diabetes. 11.4% is diabetes, but 36% is hypertension. That is the impact. Okay, let's move ahead. There's one more very interesting question on the hypertension and diabetes, this kind of a double trouble that we have in patients of diabetes. What is the prevalence, number one, and how can we prevent this?
I think, as you mentioned, almost half of the population who are having a diabetes have a hypertension in some stage of their life. And as
Yes,
the life expectancy increases, atherosclerosis as a part of the aging also would increase. So naturally, those who are having a long-standing diabetes, they are more likely to have the hypertension. Number two, hypertension patients, almost 40 to 45% would have a some sort of a type 2 diabetes. So the best thing about to tackle this double trouble is to have the healthy lifestyle to reduce the central obesity. At least 5% of their body weight loss is a must. Regular exercise, cut down on their outside food. Take the homemade food as far as possible. Once in a month is okay. But now people say occasionally means 3 times, 4 times a week they consider as a occasional outside food. Second, people consider outside food is only when they go out to the restaurant, they eat the outside food. When I ask the patient about the how frequently you take the outside food, they say once in 2 weeks, sir. But there are all the breakfast and the snaking is all outside food. Nobody takes the home cooked food now as a breakfast or a snaking. So all this outside food is not just the going out to the restaurants. All these packet foods, all the foods which we consume at home, like all these namkins, all the things has to be cut down. Decrease the salt intake by at least 25%. Decrease the fat intake by 20%. Decrease the simple carbohydrate as far as possible. Have more of a complex carbohydrate. Have more of the fibers in their diet. Have the healthier lifestyle. Have some meditation to have the reduction into the mental stress. Being endocrinologist, I know that the stress will lead to lots of stress hormones, what we call, and that again would aggravate not only diabetes and hypertension, but will aggravate the atherosclerosis also. So have some time for the meditation and a yoga. Have the healthy lifestyle, and if either of two are there, try to make sure that you are having a diabetes today, you are more likely to have the hypertension in the future. So even if you're not hypertensive now, so at least keep a check on your sugar and the blood pressure and a lipid. I think what we say, the ABC, A1C, blood pressure and the cholesterol, these three are the most important. Avoid the tobacco in any form of the tobacco. People consider tobacco only related with the cancer. I always tell that so those who I spend 5 minutes with each patient trying to make sure that they lose their habit of a tobacco, quit the tobacco. And most of the people would say that what harms tobacco does, they consider that it leads only to the cancer. They don't understand that it leads to the metabolic problem, atherosclerotic problems, infarct, stroke. Also is increased significantly. I tell that unfortunately or unfortunately, cancer occurring among say 1 in 5,000 patients consuming tobacco would develop some cancer because of the tobacco. But 80 out of 100 people who take tobacco, and if they have diabetes, hypertension, they will develop a atherosclerotic disease. So we try to tell them that it is not just the cancer we are afraid of. We are afraid about your metabolic and vascular health also is important. So all this good healthy lifestyle, and now they've got an excellent medication like SGLT2 inhibitor, which helps for your metabolic health. And we got an excellent RAS blockade available with us. So we tell our patient that if you are having a diabetes, hypertension, dyslipidemia, if you are disciplined in life, the medical science has evolved to an extent that we ensure you that you can have a longevity up to 85 years with a good quality of life. So I think this double trouble requires a overall lifestyle modification approach, and accept the fact that they are having a disease which requires, along with the lifestyle modification, a regular medication, regular health checkup, and regular consultation.
I think you're right. When you talk of diabetes and hypertension, there are common risk factors, namely obesity, dyslipidemia, insulin resistance. What Dr. DiFranzo has mentioned is the insulin resistance in the blood vessels of the muscles, which is a very important ninth component of the ominous octave, which is extended now today. And he says that this insulin resistance causes decrease in the caliber of the capillaries in the muscles, and therefore increasing the insulin resistance even the muscles also. That results into hypertension. Plus we have the multiple genes which ultimately bring the diabetes and hypertension together, and therefore they have a common existence. Therefore 50% of diabetics have hypertension and 40% of hypertensives have diabetes. Both of them together result into atherosclerosis, as you mentioned, endothelial dysfunction, and a vascular fibrosis, vascular inflammation, and arterial remodeling. And because of that, you get a microvascular and a macrovascular complication. And that's how the diabetes and hypertension makes a double trouble, and therefore has all possible complications to the patients of diabetes. I think we have another 5 to 6 minutes for the last two questions. And one of the important questions there is a rural and urban divide. It is said in the rural population there's more of a diabetes, whereas urban population is more of a hypertension. This is what is the survey which is found out. Then how do you explain the association of a higher incidence of diabetes in the rural population and a high incidence of hypertension in the urban population? How do you explain that?
I think hypertension is uh, more commonly linked with the amount of stress compared to the diabetes risk, because hypertension and the stress has a very stronger correlations compared to diabetes and stress. Both has a correlations, but because of the stress, all these catecholamines would be increased. It will not be like in a very high pharmacological or supraphysiological levels, but it will be on the higher side, leading to the hypertension. So we know the life of a urban person versus the rural persons, time bound jobs, commitments, traffic problems, stress of the job or a study, all these together would have a urban population having a more hypertension. Diabetic in a rural population again is probably increasing rapidly because of the now the awareness about the diabetes and among the primary healthcare physicians. So lots of diabetes is picked up also early in the rural area. Previously, it was considered to be Raj Rog, present only in the affluent class, and now everybody knows that no, everybody has a uh, tendency to have develop diabetes. So people are probably in the rural areas also are checking more for the diabetes also. And I think in a near future, the urban rural divide is going to be blurred, and it will be almost similar, if not significantly different, because most of the farmers also don't actually do a physical activity. They do the all the farmings with the all the modern equipments. So gradually, sedentary life is penetrating to the rural populations also. So gradually, in the next couple of decades, I think there will be hardly any difference between urban and the rural populations.
I think you're right. There's a good study called LASI study, which looked at longitudinal aging study of India, which looked at 52,000 patients in India and was trying to find out the prevalence of hypertension and diabetes. And in the rural areas, it is the more of the poverty and the eating the processed food and therefore cheap food, and that's why the incidence of diabetes is pretty high in the elderly, in the population, actually elderly in the urban area. The stress, the education, the lack of physical activity, and little more of affluence has probably brought more hypertension in the urban areas. Okay, then we'll come to the important question between the sex differentiation. We feel that the hypertension is much more common in the female sex compared to male sex. If you see number of patients of hypertension, the females are definitely outnumber the male patients. How do you explain this disparity between male and female so far as the incidence of blood pressure is concerned?
Not a very good scientific reason to explain from pathophysiological point of view that why females would have a more hypertension compared to the males, because the amount of stress to the male versus female, naturally male would have a more proportion of the males would having a more stress, though now the working class females are increasing significantly. Sedentary life, I think, is one of the common more common among the females. Now household world is available, all the equipments are available, so female are busy in their homemaking, and many of them are doing a job as well as they're to look after the small kids, so they don't have a time to do a exercise. The food also is available to the female uh, uh, at their discretions compared to the working males or working females. So that might be one of the reasons, apart from the central obesity. Again, we have seen that PCOS is increasing significantly. So insulin resistance also is increasing significantly among the female at a younger age compared to the males also.
Yeah, I think you're right. Beyond the age of 30 years, there's a steep rise of blood pressure in females, and both in systolic and diastolic blood pressure. As you mentioned rightly, the PCOS, and many times the clinicians use the hormone therapy for them, and therefore they can cause hypertension. In the pregnancy, they can what is called pregnancy-induced hypertension or gestational hypertension is very common. Preeclampsia is very common. These are the forerunners of the subsequent hypertension they get menopause is another important cause for hypertension, and there's one specific condition called fibromuscular dysplasia, which is also predominantly common in the female sex, and therefore you find the female sex has more hypertension than the male sex. Okay, I think that comes to the last question. We saw the pandemic of COVID, and this pandemic COVID was very devastating, both in terms of financial, physical, social, and of course, the medical problems to the patient. What do you feel the impact of COVID has happened in India from the hypertension, diabetes point of view? How has the
Yeah, I
COVID
think,
impacted?
see, there are two things. One thing is COVID has unmasked lots of hidden underlying pre-diabetic or a diabetic or hypertensive populations, because almost 60-70% of the population developed the COVID during first, second, or third wave together in India. So during their health checkup, the sugar and the blood pressure was checked. At least sugar was checked more frequently. Blood pressure also was checked because of lots of medication, including steroids to be given. So you have to monitor the sugar. So lots of unmasking occurred. Number two, the lifestyle has changed significantly. Lots of people have started going working from the home is a norm, specifically in the many fields like IT fields. Many of the remote BPOs and all now have started working from the home. So many people still are working from the home, and they have got developed a totally a different sedentary lifestyle, like late night being awake. OTT platform, for example, has significantly penetrated after the COVID. So people have become more potato type of the food habits have increased. People keep on watching till 1 o'clock at night, even if they're not working till late night. So if you are awake, you feel hungry, and then you grab something. So this together, and of course, COVID, we all know, was a state of a hypercoagulability. So lots of hypercoagulability states had a impact on the vascular health of the people, and those who were underlying some metabolic disturbances, they got a more aggravated increase into the hypertension as well as the diabetes. And people consider that COVID medications would not have a very long lasting effect of like a short course of a steroids would not have a effect after 1.5 or 2 years, they are still diabetics.
Yeah, I think true, because not only during COVID, but even the post-COVID syndromes were also very important. A lot of cardiovascular, neurological, musculoskeletal manifestations were seen. A lot of people have arrhythmias because of the post-COVID state. They had hypertension, weakness, fatigue. A lot of symptoms were described in the post-COVID state, which carried on for more than 2 years. Some people had problems with COVID vaccination, especially those who had taken the RNA vaccination, also had problems of cardiovascular manifestation. COVID, besides COVID itself, had a medical, physical, social, for example, isolation, domestic violence, all those problems were very much seen. The psychological problems were seen, and also financial constraint also brought a lot of problems to the human beings and mankind at large, and therefore brought the grinding halt to the medical management also for these patients because of lack of accessibility. They could not reach the hospital. Even the hospital would not admit such patients because they were full with COVID patients, and therefore people had a lot of sufferings because of COVID pandemic. So I think with that we complete today's discussion. It was a wonderful discussion with you, Dr. Paraksha. It was a lot of learning
Yes, sir. Yes.
experience, a lot of learning experience. I learned a lot of new things. I hope even everybody who's watching this program also had learned many things from your experience in endocrinology and hypertension. Do you want to give finally 1 minute message to the people who listen to you from the hypertension, diabetes perspective? What is your carry home message? 1 minute carry home message.
Yeah, I think most important is to have the healthy lifestyle to be taught right from the early childhood. We teach the small kid to brush the teeth daily, not to lie, not to steal. Okay, but we never teach them that you have to do exercise daily. So I think early, unless we embark the exercise habit right from the early childhood, it's very difficult after 30 years or 40 years of age to have the inner desire to have the healthy lifestyle. So that has to be brought right from the early childhood, and that has to come for the family. You cannot isolate one person from the family. I am diabetic, I will eat a different food. It's not going to be happen. So healthy lifestyle, including regular exercise. Keep a watch on your waistline. I think that is very, very crucial. Weigh yourself daily. Make sure that you don't gain weight, and as soon as you gain weight, you try to restrict the further weight gain and try to lose even half a kg weight gain. You become alert. Otherwise, you keep on adding this weight to your body, specifically central part. Third, accept the fact that diabetic and hypertension are a metabolic problems. They are going to be remain silent. You will not have any symptoms, but it will lead to lots of morbidity, macrovascular complications, and early mortality. Accept the disease, take the proper advice, don't stop medications unless advised by the doctor. I always tell to my patient that we don't repair the 1000 rupees mixie of our own looking at a YouTube video. Okay, our body is a wonderful body which cost you cannot imagine the cost of our body. So why we want to repair our body by going to the Google and going to the YouTube? Okay, when your TV is at fault, you go to the mechanic, the proper service center, spend money. You drive a car or a bike every 3 or 6 months. You spend few thousand rupees just to make sure that car and the bike is in a proper shape. Spend some uh, money for your health. Spend time for your health. That will give you a productive life, a good quality of life for at least 80 years of your age.
I think that's right. What Dr. Paraksha says is healthy lifestyle, maintain your weight, refrain from all the habits like smoking, tobacco, and alcohol, and of course physical activity is very important. Medications are there to help you. Adherence to medication is also important, and for that the education is of paramount importance. And I think all these factors, if they carry right message, I think you can control patients of hypertension, diabetes very effectively and meaningfully. With that, we conclude today's talk. Thank you very much, Dr. Paraksha, for your.
Thank you, Dr. Sir. Vijay, sir. Thank you.
Thank you very much.
Very good evening to all of you who have joined. Warm wishes for Akshaya Tritiya and Eid to all the panelists, supporting staff, as well as all of those who have joined. Today is an auspicious day, and Akshay meaning something that does not, that stays intact, and we always want our bones to be akshay, something that does not break. And that is why this attempt to diagnose as well as treat osteoporosis so that we beat the break in the bones. I would express my gratitudes to IJCP for organizing this in association with International Osteoporosis Federation and ISBMR, and Team Alchem for sponsoring this wonderful initiative. Today's webinar is fifth in the series. Again, gratitudes to all who have joined, and it's my utmost pleasure to welcome our guest speaker, or who is also going to be our first speaker, Professor Dr. Paul Zulk. Professor Pavel is MD, PhD, and alumni of Department of Endocrinology, Medical Center Postgraduate Education Institute in Warsaw, and currently working as a clinic as researcher at the prestigious INSERM in Lyon, France. His scientific interests include osteoporosis in men, bone turnover markers, cardiovascular diseases and osteoporosis connect, sarcopenia, and he has been an author and co-author of more than 150 publications and papers as well as chapters in the textbook. He is a member of many prestigious organizations, most notably ASBMR, and we will be having the pleasure of listening to Professor Pavel regarding one topic of bone turnover markers. Bone is usually a little sedate tissue, and even a BMD shows a lot of, takes a lot of time to show changes. But what shows a change early are the bone turnover markers, and we'll be listening to Professor Pavel regarding that. I also have the pleasure of welcoming Dr. Sahana Shetty, who is a professor of endocrinology from prestigious Manipal Institute, Kasturba Hospital, Mahe, and has a interest in osteoporosis. She has won the ISBMR awards for her presentations at Srinagar, Delhi, and Mumbai, and she's an alumni of prestigious CMC Vellore. And I am your host for today, as well as a presenter of a topic called as diabetes and osteoporosis practical approach. I am Dr. Ameya Joshi. I am Director of Endocrine and Diabetes Clinics Mumbai and consultant endocrinologist at Bhaktivedanta Hospital and Research Institute. I am currently Secretary of Maha Endocrine Society. So, as we move on to the program, I think we all are aware of how to diagnose osteoporosis and also the treatment armamentarium, which has been discussed in the previous webinar. We also know that we monitor the changes in the BMD by DXA, but it takes a time, almost a year or two, to show a meaningful change. So, how to know whether your treatment that you are giving or maybe the intervention that you are doing is working or not? One modality of looking at it, which is more dynamic, is the bone turnover markers. And it's my utmost pleasure to invite Professor Pavel. For those who joined a little late, Professor Pavel is currently a researcher at prestigious INSERM Lyon, France, with specific interests in osteoporosis in men and bone turnover markers. It's over to you, Professor Pavel.
Okay. Can I start?
Yes,
Can
sir.
you yes? Can you please show my slides? Okay. So, good evening, chairpersons, ladies and gentlemen. First, I would like to thank the organizing committee for inviting me to this meeting. However, I would like to add one rectification. I am only doctor. I am not professor. So, doctor. So, International Osteoporosis Foundation and the International Federation of Clinical Chemistry identified N-terminal extension propeptide of type 1 procollagen as the reference marker of bone formation, and C-terminal telepeptide of type 1 collagen as the reference marker of bone resorption. Therefore, my presentation will be focused on these two markers. P1NP may be measured in serum and plasma, and it is stable at room temperature. By contrast, the short-term stability of CTX depends on the type of sample. CTX1 is stable in plasma stabilized by EDTA. By contrast, it is less stable in serum. Therefore, EDTA plasma is preferable if the sample cannot be processed rapidly or if it has to be sent to a remote laboratory. It is obligatory to use the same sample type for monitoring a patient. The patient-related sources of pre-analytical variation comprise controllable factors and those which cannot be easily controlled. In my presentation, I would like to focus on the most important factors from the point of biological and clinical point of view. Serum CTX1 exhibits a substantial circadian variability. Its levels are the highest in the early morning and rapidly decrease after breakfast. The amplitude of these variations is much higher than the measurement error of the immunoassays, shown you see by this small red rectangle. P1NP also shows a slight circadian variation. However, its amplitude is much smaller and comparable with the measurement error of the immunoassays, which is also showed here by this small red rectangle. Therefore, if both markers are measured, it is necessary to collect blood sample after an overnight fast between 7 and 9 a.m. By contrast, fasting is not necessary and a random sample is acceptable if only P1NP is measured. A fracture may induces a rapid increase in bone formation, which is followed by a slower increase in it's a rapid increase in bone resorption, which is followed by a rapid increase in bone formation. As you can see, bone turnover may take even 1 year to return to baseline, especially in case of fractures with large surface of consolidation. And very important point, often forgotten, is that a vertebral fracture also induces an increase in bone turnover rate, which lasts for several months. Finally, large orthopedic surgeries induce a local acceleration of bone turnover, which results in an increase in the levels of bone turnover markers. Therefore, the information on fractures and orthopedic surgeries in the previous 12 months should be, or during the anti-osteoporosis treatment, should be strictly noted down in medical records and then considered in the interpretation of the results. Moreover, many conditions may influence bone turnover. Bone turnover is accelerated in patients with thyrotoxicosis, with primary hyperparathyroidism, hypogonadism, or Paget's disease. Bone turnover is low in hypoparathyroidism, hypothyroidism, and growth hormone deficit. Dissociation of bone turnover is defined by an increase in bone resorption, which is accompanied by a low or normal bone formation. This imbalance between the high bone resorption and low or normal bone formation is observed in rheumatoid arthritis and in general in inflammatory diseases, in multiple myeloma, especially newly diagnosed multiple myeloma, Cushing's disease, Crohn's disease, liver diseases, or HIV infection. In addition, various medications may also influence bone turnover rate. Therefore, the individual patient-related conditions should be noted down in the medical records and then carefully taken into account for the interpretation of the results. Now, let's talk about the utility of bone markers in osteoporosis. In postmenopausal osteoporotic women, average concentration of serum CTX1 was higher in comparison with premenopausal women. However, only 20% of them had serum CTX concentrations exceeding the upper level of the normal range. And in most of them, as you can see, the levels were only slightly elevated. In addition, these very high concentrations of CTX1 marked by the red ellipse should be interpreted with caution, because very high levels of bone markers may be observed in primary hyperparathyroidism, Paget's disease, multiple myeloma, or bone metastases. Thus, the measurement of bone markers does not permit to diagnose osteoporosis, but may help to exclude secondary causes of low bone mineral density. Several studies assessed the association between the baseline level of bone turnover markers and the subsequent bone loss. In this study, we can see the association between the bone loss at the lumbar spine and the baseline levels of different bone markers. As you can see, for all the markers, the correlation were negative and significant. This is shown in the red rectangles. However, if you look at the blue rectangles, you can see that for a given level of every marker, there could be a high scatter of individual values ranging from apparent bone gain to the evident bone loss. In several prospective studies, higher levels of bone turnover markers were associated with higher risk of fracture. However, these early enthusiastic opinions had to be toned down. Let's take this meta-analysis, which was published nearly 10 years ago, but still is valuable. In general, higher serum concentrations of CTX1 were associated with higher risk of fracture. However, some studies were carried out in women, W, and others in men, M, on this far left column. The studies differed in terms of the investigated fracture, hip fracture, all fracture, non-vertebral, all clinical, etc. The associations were stronger and significant in the studies where the time of blood collection was standardized, but consistently non-significant in these three studies in the middle when blood was collected at random. And even these positive results should be interpreted cautiously because these analyses were not adjusted for bone mineral density measured by DEXA. Thus, from a pathophysiological point of view, the significant association of the levels of bone turnover markers with the rate of bone loss and with the subsequent risk of fracture shows that high bone turnover is a determinant of the aging-related bone loss and bone fragility. However, from the clinical point of view, bone markers cannot be used for the prediction of the accelerated bone loss or fracture at the individual level. In the clinical practice, bone markers permit to monitor the anti-osteoporosis treatment. A recently developed algorithm shows how to use serum P1NP for this purpose. Let's start with the anti-resorptive therapy. P1NP is measured twice, at baseline and after 6 months of treatment. The algorithm defines two targets. The target concentration is less than 35 nanograms per milliliter, which corresponds to the median concentration in young premenopausal women. The target change of 10 nanograms per milliliter corresponds to the least significant change, and this has been calculated on the basis of the measurement error of the immunoassay and of the within individual variability. Let's look at the main types of response. A significant black line, a significant decrease to below 35 nanograms per milliliter is an optimal response. Now, the red line, the significant decrease, but not to below 35 nanograms per milliliter, may occur in patients who have very high P1NP concentrations at baseline. This situation may occur in the case of a recent fracture or in patients having the diseases affecting the P1NP levels, such as skin diseases, liver dysfunction, or kidney disease if total P1NP is used. If this is not the case and the compliance is correct, P1NP should be measured again after 3 additional months. Now, let's have a look at this black dotted line. Thus, the situation where P1NP does not decrease and remains above the target threshold. In such case, the first thing to do is to check the compliance. Now, let's move to the yellow line. That at baseline the concentrations of P1NP are low, below the target value. Obviously, in this group, the anti-fracture efficacy may be, according to some studies, lower. But anyway, it is a good news that the levels of bone markers are low during the treatment. By contrast, and this is this dotted green line and this big rectangle here, the most important warning is an increase in P1NP during the treatment. It may be due to a recent fracture or due to a recent development of a disease affecting bone, affecting P1NP. Now let's move to the second part of the algorithm concerning the monitoring of the anabolic treatment. Here, P1NP is measured 3 times, at baseline and after 1 and 3 months of treatment. Again, the algorithm defines 2 targets: the increase by more than 10, increase in this case by more than 10 nanograms per milliliter, and the level of 69 nanograms per milliliter, which corresponds to the upper limit of the normal range in young women. And now there are several types of response. Patients who meet both criteria, I mean the black line that the increase is more than 10 nanograms per milliliter and the threshold is exceeded. This is the optimal response. However, we should not forget the possibility of a recent fracture of another disease. Now, the red line, the increase is okay, but the levels remains below the target value. It may occur in patients who had very low concentrations of P1NP at baseline. The compliance should be checked, and if the compliance is correct, the measurement of P1NP should be repeated after 2 additional months. By contrast, the greatest problem is this green line increase of less than 10 nanograms per milliliter of if P1NP is stable or even decrease. Here, this is a major warning because this pattern may be due to issues with compliance, drug storage, or injection technique. Furthermore, bone markers may be used for assessment of the bone turnover after discontinuation of the anti-osteoporotic treatment. After 5 years of treatment with alendronate, the concentrations of CTX1 and P1NP were below the baseline values, and the baseline values are shown by these red lines. Then, women who continued alendronate had stable levels of bone markers, which is shown by the black points. By contrast, the circles which correspond to the women who switched to placebo show an increase in both bone markers. And as you can see, both markers increased by about 50% over 5 years. And this rise in bone turnover rate had an impact on bone mineral density. As the lumbar spine, bone mineral density increased in both groups, probably due to the development of osteoarthritis, but less so in women taking placebo, white points. At the total hip, bone mineral density decreased in women who switched to placebo, but remained stable in women who continued alendronate and who are presented by black points. Now, let's move on to the raloxifene. Raloxifene decreased the concentrations of bone turnover markers. However, after cessation of treatment, the bone turnover increased, and 2 years later, bone markers returned to the baseline values. In postmenopausal osteoporotic women, denosumab was administered for 2 years. Bone markers decreased rapidly after the first dose and then remained low on treatment. However, after this denosumab discontinuation, bone resorption increased rapidly and was followed by an increase in bone formation. As you can see, the values were about 50% higher in comparison with the baseline concentrations. And this increase in bone turnover was associated with a rapid decrease in bone mineral density. Now there is a very complicated slide, because this study assessed the effect of zoledronate after denosumab discontinuation in 61 men and women who had been treated with denosumab for at least 2 years. They were randomized into 3 groups. The first group received the zoledronate infusion 6 months after the last denosumab injection, and this point defined the baseline for this study. The second group had medical visits every month. These are these blue bars, and received zoledronate infusion if they had high CTX or low trauma fracture, but no later than 3 months after baseline. In other words, 9 months after the last denosumab injection. And the third group had similar medical visits for 6 months, every month, these blue bars. They received zoledronate if there was a problem, but no later than 6 months after baseline. In other words, 1 year after the last denosumab injection. Then they had the on-treatment visits presented by the red point, 1 month, 1, 3, 6, and 12 months after the zoledronate infusion. And in some cases, if any patient fulfills any of these criteria, they had additional zoledronate infusion. Now, what happens with bone markers? As you can see, in the first group who received zoledronate 6 months after the last denosumab injection, bone resorption remained stable, but it increased progressively, and after 6 months, attained the levels which corresponded to the upper limit of the normal range in premenopausal women. And this increase was followed by a slower increase in P1NP, which is presented by the red line on the lower panel. Now, let's take the green line, which presents the women who had the zoledronate infusion 3 months after baseline. Thus, at the beginning, there is an important increase in bone resorption, decrease in bone resorption after zoledronate infusion, but again, the re-increase in bone resorption 6 months after the zoledronate infusion. The changes in bone resorption were followed by similar changes in bone formation. And as you can see, most of women had CTX concentrations which exceeded the upper limit of the normal range for premenopausal women. And in the third group, the pattern was similar, rapid increase, then the decrease after zoledronate infusion, and again, re-increase after 6 months. The concentrations of CTX1 were much higher than the upper limit of the normal range in premenopausal women. Thus, in conclusion, in summary, the use of bone markers may improve the monitoring of the anti-osteoporotic treatment, and bone markers help to understand changes in bone mineral density after discontinuation of the anti-osteoporotic treatment and may provide indications for additional therapeutic interventions. Thank you very much for your attention.
Thank you, Dr. Pavel, for the, I must say, very crisp, practical, and to the point deliberation.
Thank you.
I would request you to stay back with us for question and answers after the second talk of the day. And yeah, so we move on to the second talk of the day. And as we all know, the chronic pandemic that is going on is a pandemic of diabetes. When we think of diabetes, we think of heart disease, we think of a kidney disease, we may think of an eye disease, but very rarely does it cross our mind that osteoporosis, or more notably, weak bones, even with a apparently good BMD, can be a part of a diabetes spectrum. And so, in next 15 to 20 minutes, I'll be taking you through a journey of practical approach in managing osteoporosis in people with diabetes. Meanwhile, all the listeners can also put forward their questions, which will be taken in the panel discussion. Can you please put up my slides? Yeah. So, good evening, all of you. And I'll be discussing about practical approach in managing osteoporosis in people with diabetes. Next slide, please. And to start with, we have a clinical case of a 55 lady who is diabetic since 20 years, came with aches and pains, actually did a BMD as a part of her health checkup. She is obese, hypertensive, and has peripheral neuropathy and chronic kidney disease with albuminuria. She is on metformin, gliclazide, gliptin, canagliflozin, and pioglitazone, and reasonably well controlled. She is hypertensive on telmisartan and on rosuvastatin for dyslipidemia. Next slide, please. Her BMD showed that the T score at spine was -2. So we will try to see how to approach this case, and we'll briefly discuss about why think of osteoporosis as a complication of diabetes, then about factors affecting bone health and why fracture risk is beyond bone density in diabetes, and then briefly touch upon type 1 diabetes and then summarize. Next slide, please. So when we think of osteoporosis, the classification is a normal BMD between +1 to -1, osteopenia when the T score, which is a Caucasian woman between second to third decade compared with the index patient, if it is between -1 to -2.5, where our patient is, it is called as osteopenia. And osteoporosis is when the BMD is worse than -2.5. Most of the times, patients between -1 to -2.5 are prescribed lifestyle modification, are prescribed diet, exercise, calcium, but not the actual osteoporosis therapeutics. And osteoporosis ranged get the therapeutics. But we need to look at diabetics differently, and maybe diabetics in osteopenia range may become targets for therapeutic intervention. Next slide, please. Next slide. Yeah. So when we think of osteoporosis, the definition comes with two essentialities. A disease characterized by low bone mass and microarchitectural deterioration of the bone. And in diabetes, it is this microarchitectural deterioration of the bone is a problem which cannot be assessed that well by the conventional DXA. Next slide, please. So, when we think of diabetes, we think of complications, and the chronic complications are broadly divided as microvascular, neuropathy, nephropathy, and retinopathy, or macrovascular, cardiovascular, cerebrovascular, or peripheral vascular disease. Next slide, please. And then when we think of bone disease, we think where does it stand? Next, please. Whether it is a micro or a macrovascular disease. And the factor responsible for microvascular complication are the advanced glycation end products. So your glucose liases on with the proteins to form unfavorable bases which accumulate in various tissues, here bone, and increase the brittleness of the bone and slow the bone turnover, reducing the bone strength independent of the BMD. Next slide, please. So diabetics have weak bones independent of BMD, and it has been found that when the advanced glycation end product levels were assayed in a diabetic patient, so in a person with diabetes, if the advanced glycation end products are more, then they are more at risk of fractures, which is independent of BMD. Next slide, please. So these advanced glycation end products correlate with microvascular disease. So whenever you see a diabetic patient, and when he says that okay, he has a kidney disease, he has got neuropathy, or she has got neuropathy, or she has got retinopathy, always keep associated worse bone health, even worse than what's shown by BMD in your mind. But is there anything that can be added to a conventional BMD and get a better idea of bone health? And yes, that's something called as a trabecular bone score. It is being more and more available in centers in India. Few centers have got it. One center in Mumbai has also got it. And what we see is, even though the bone density is better in type 2 diabetes, the trabecular bone scores are lower, indicating the bone quality is poorer in type 2 diabetics. Next slide, please. And this is from a Manitoba cohort. These two studies from India, one by Dr. Thomas Paul, looked at 200 cases with controls, and they found that lumbar spine osteoporosis was less commonly seen in type 2 diabetes, but the trabecular bone scores were worse in type 2 diabetics. And Dr. Kamal Nathan concluded that though BMD was better in type 2 diabetes, the effect was mainly due to the high body mass indices in type 2 diabetes. Next slide, please. So what we conclude is a poor bone microarchitecture which can be assessed by a trabecular bone score, and this trabecular bone score gives you an idea about the architecture, and worse than 1.2 is an indication that the basically if the trabecular bone score is uh, 1.2 or worse, then that is an indication that the architecture is poorer. And you can see that at same BMD you can get a worse trabecular bone score in if the bone is not proper in architecture, which is what we can see. Next slide, please. So TBS has been recommended for assessing fracture risk in type 2 diabetes. Next slide, please. So if you have an option, ask for a TBS. In couple of years, maybe many more centers will have TBS. And then you can have other modalities like QCT or HRP QCT, which show decreased bone area, and dynamics like microindentation techniques, which show decreased material strength of the bone in type 2 diabetes. Next slide, please. So let us try to look at what adversely affects the bone health. Next slide, please, in diabetes. And then you look at a lot of factors. Vitamin D deficiency, more common in diabetics, but those diabetics who are poorly controlled have low IGF-1 levels. So bone formation is poorer, cortisol levels are high, hypogonadism, much more common in type 2 diabetics, especially they have sleep apnea, and CKD, which is also much more common in type 2 diabetes, entirely opens a new chapter of bone insults. So these are the factors which are specific to diabetes and can contribute to worse bone health. Next slide, please. And what is worse in diabetics is the muscle that gets affected, either because of the factors that we discussed or because of the genetic reasons and the dietary reasons. Most of Indian diabetics are actually protein deficient, and the weak muscle forms a exact nidus for a fall, and the bone which is distorted is more likely to fracture. Next slide, please. Now, what goes on with type 2 diabetes is obesity, and typically fat improves the BMD, is what is thought of because it's a good source of estrogen. But an counter argument also states that obese are more likely to have vitamin D deficiency and hypogonadism, and you can actually get a bone density that looks maybe apparently better, but is actually not that good. So fat can be even counterproductive for the bone density or bone quality in particular. Next slide, please. And then bariatric surgery is something that is offered as a therapeutic in type 2 diabetes, and it also initiates a lot of problems for the bone, including nutritional deficiencies and the cytokine changes. Next slide, please, including the catabolic state. So what we see in a nutshell is the reduced turnover, abnormal biomechanics, and reduced bone quality in type 2 diabetes. Next slide, please. And the meta-analysis done by both Peter Westergaard and Zangorbini actually concluded that for the same BMD, which appears little better in type 2 diabetics, the risk of fracture is actually much more in type 2 diabetics, almost 1.5 to 2 times as compared to controls. And so type 2 diabetics at a similar BMD are at more risk of fracture. Next slide, please. And when you look at what can be the contributing factors, one is a poor architecture, but falls are much more common in diabetics because of neuropathy and hypoglycemia. Thiazolidinediones change the bone turnover. Metabolic abnormalities and skeletal abnormalities contribute more to the risk of fractures in type 2 diabetics. Next slide, please. So the falls occur because of peripheral neuropathy, poor vision. So as I told, microvascular disease, neuropathy and retinopathy going hand in hand to the bone disease. So a good combination, exact nidus for the fall. Arrhythmias more common in diabetics, cerebrovascular episodes more common in diabetics, hypoglycemia, especially with insulin and sulfonylurea use, peculiar to diabetes. All of them are more likely to cause excess chances of falling and thereby risk of fracture in a bone which is already distorted in architecture in type 2 diabetics. Next slide, please. Now let us try to look at this particular molecule called as thiazolidinedione, and let me remind you that our patient was on pioglitazone. What does thiazolidinedione do is they change the mesenchymal progenitor cell to the adipocyte and not the osteoblast. So the progenitor doesn't form the bone, the progenitor forms adipose tissue. And as a result of that, the adipose tissue grows in a person and the bone becomes, I would say, static or is not that well formed. And as a result of that, patients on thiazolidinedione are more likely to have fractures, poorer BMD, and increased risk of or poor bone healing or fracture healing. Next slide, please. So thiazolidinedione use has been unequivocally linked with the excess chances of fracture almost 5 to 10% increase or 2 to 3-fold increase in the risk is seen in diabetics who are on thiazolidinedione as compared to other therapeutics. Next slide, please. There was some noise about SGLT2 inhibitor canagliflozin. However, the data that came later on actually reassured that fracture may be selective to canagliflozin, that too at frail and extreme of ages population. Next slide, please. And then we move on to, if the BMD is not enough, does the FRAX algorithm predict fracture in type 2 diabetes? And then we look at the determinants of FRAX and find age, sex, weight, height, rheumatoid arthritis, previous fractures, smoking, etc., etc., etc. But we don't overtly see diabetes in the FRAX algorithm. But if we implement FRAX in a diabetes, we find that FRAX also underestimates the risk of fracture, and the risk of fracture increases from non-diabetic to a diabetic not on insulin, and is much more in a diabetic who is actually on insulin. So FRAX underestimates your fracture risk. Next slide, please. And this is the input of the FRAX, and you cannot see diabetes overtly. Next slide, please. But if you look at the row below, you see that they have further classified on which thing to be ticked. And secondary osteoporosis, diabetes is now acknowledged to be one of the causes of secondary osteoporosis. And in a FRAX, when you calculate it for a diabetic person, do tick for secondary osteoporosis. And even, I would say, many studies have shown that the BMD should be minus 0.5 to minus 0.6 added, or basically minus 0.5 minus 0.6 worse as compared to a normal person. So our patient had a BMD of minus 2. We need to read it as minus 2.5, minus 2.6. And AAC guidelines have also acknowledged the fracture risk. Next slide, please, in diabetic. And this is what we discussed about the molecular as well as the actual things that happen in a diabetic bone. Next slide, please. And this is how you need to approach in a diabetic person. Do a proper risk stratification, acknowledge the increased risk, and also look at the comorbidities that contribute to fracture, as well as the other aspects like therapeutics. Next slide, please, which could also increase the risk of osteoporosis. Now moving on, in last couple of minutes, about type 1 diabetes. Type 1 diabetes usually occurs at a younger age. Children are insulin dependent usually, though it can occur at later ages, but it unequivocally reduces the bone density. So type 2 diabetes, better bone density, but much more high fracture risk. Type 1 diabetes, poor bone density and a significantly high fracture risk. Next slide, please. So this is our own original study looking at type 1 diabetics, and this is the first study from India. Post that, couple of more studies were done. Next slide, please. And we found a poorer lumbar spine bone density as well as a total body BMD in type 1 diabetics as compared to age and sex match control. A study that has been concurrent with quite a few of meta-analysis as well as multiple studies across the globe. Next slide, please. And this is about the Indian studies. The latest one was by Dr. Khadilkar, which looked at TBS in type 1 diabetics and controls, and it further said that the BMD is poor, but the TBS is even worse in people with type 1 diabetics as compared to the control. So a lot of agony for the bone in type 1 diabetics. Next slide, please. So let us try to look at the causes or factors that can affect, and always screen type 1 diabetics for gluten sensitivity, because that can worsen the bone health. Poor glucose control resulted in lower IGF-1 levels, and those type 1 diabetics who had an earlier age of onset, the bone loss started at an early age, or a peak bone mass could not be achieved, remained at much higher risk of fracture, had much worse bone densities, and also the complications that add on later on in life like neuropathy and renal failure worsen the bone density as well as increase the fracture risk. Next slide, please. So now let us come back to summarize practically what we learned and apply it to the case. what is most important is assessing bone health in type 2 diabetes as well as type 1 diabetes. If you don't assess, you don't see. If you don't see, you don't treat, and drugs don't work in people who do not take them. So type 2 diabetes or type 1 diabetes, annual assessment goes to ECG, microalbuminuria, cardiac assessment, retina assessment, neuropathy assessment. Bone assessment has also to be done. I personally prefer all postmenopausal females in short, or basically those type 1 diabetics who are lacking in terms of height also are offered BMD, as well as men above 50 are offered BMD. Guidelines are needed to be developed in this area. The therapeutics should always be bone friendly, and if possible never use thiazolidinedions. Also, in case, it is better to consider insulins which have less risk of hypoglycemia. It's a good clinical practice to supplement calcium and vitamin D. Exercise improves BMD. Exercise advice should be given to all type 2 and type 1 diabetics. Fall prevention, liberal use of sticks in people with neuropathy as well as retinopathy. Those who are indicated should be given therapeutics, either teriparatide, denosumab, bisphosphonate. Our patient was started on alendronate, and hypoglycemia prevention. Do any and everything to prevent hypoglycemia. Next slide, please. So to summarize, good to screen for bone density. Consider type 2 diabetes as the risk factor for fractures. While treatment, avoid hypoglycemia and use bone-friendly medications, calcium and vitamin D repletion, treatment of indicated. Next slide, please. So to summarize, fracture risk is greater in diabetics. Contributing factors include falls, obesity, medications, and the bone quality that worsens. Intensive glucose control may not increase fracture risk, but any medication that causes hypoglycemia does increase. Standard guidelines should be applied to type 2 diabetics as well as type 1 diabetics and emphasized in them because fracture risk is more, and the deserved should get assessment as well as treatment for the bone health improvement measures. Next slide, please. I thank you one and all for your patient listening, and we move on to our question answer session. Thank you for the patient listening once again, and I request the tech team to invite Dr. Sahana back. For those who joined late, Dr. Sahana is professor of endocrinology at Manipal Hospital in Mangalore. We also have the pleasure of introducing our orthopedic colleague joining for the day, Dr. Oberoi from Dr. Nitiraj Oberoi from Max Saket Hospital, New Delhi. He is Associate Director of the Joint Replacement Program there. Dr. Oberoi, is he here with us? Okay. So we have just got a confirmation that Dr. Oberoi has not joined. Probably he is fixing a fracture somewhere. I think, let's hope so. But we have some good questions. So maybe can I start taking them? Maybe let me start with the first question. That it's an interesting comment actually. Why BMD is declining and the patient is not taking? So let me frame a question for Dr. Pavel, that osteoporosis is something that is aggressively treated, but maximum fractures occur in osteopenia range. So if you look at the number of people in osteopenia range, that's huge, and the number of fractures maximum occur when people are in the osteopenia range. So any practical tips about use of bone turnover markers in this population to guide therapeutics?
No, it's an interesting question because I think that most probably there are other factors which should be taken into account in osteopenic patients. The first point is the presence of the fragility fracture, because if the patient has the bone mineral density in the osteopenic range but she or he has already had a fragility fracture, especially major fragility fracture like clinical vertebral fracture or hip fracture, this patient should be considered as a patient at high risk of another fracture and should be treated. The second point is, for instance, osteopenic range, but if it's, but where? If it is, let's say, minus 1.6, we can repeat bone densitometry in 7 years. If it is minus 2.4, bone density should be repeated in 2 or 3 years. And in fact, in these patients, it would be interesting to see if they have high bone turnover rate, because this higher bone turnover rate may be an additional risk factor increasing bone fragility. Because in this group, higher bone turnover rate may be associated with greater bone loss, with greater deterioration of bone microarchitecture, with the trabecular perforations, and also with a higher fraction of newly formed bone, which has not undergone the full mineralization and full post-translational modifications. Thus, in fact, in this group of osteopenic patients which are close to the osteoporosis threshold, I think that bone markers could provide some additional information and could be useful for the better diagnosis of the risk of fragility fracture. And obviously, as always, as I said, bone markers, very high levels of bone markers may help to exclude the secondary causes of low bone mineral density.
Thank you. Dr. Sana, you would like to add something?
Yes, I think I very much agree with what Dr. Paul has mentioned. Like at present, the best modality we have for diagnosing osteoporosis is DEXA, because we know with decline in BMD there's a fracture risk. But it's also true that 50% of the patients who have fragility fracture do not have DEXA BMD in the osteoporotic range, and that is where this clinical risk factor tools like FRAX come into picture. So the decision to treat or not to treat should not only include DEXA BMD, but also this risk factors, and tools like FRAX are really useful in these aspects. Now BTMs, although there is some, I mean, we know that higher BTMs might predict an ongoing accelerated turnover. We do not exactly have clinical trial data telling that whether it's helpful in osteopenic patients to decide therapy, but it might add to the treatment decisions, but we cannot take it as a tool to kind of decide therapy at present, because we do not have complete evidence on that aspect. Probably a study which includes osteopenic patients and then BTMs, and then look at the fracture outcome would be helpful. As of now, I think we should mostly rely on, other than BMD, mostly rely on the clinical risk factors to make decisions on whether to treat or not treat the patient.
Yeah, I think very well said and practical. Dr. Sana, I have an interesting pair of questions for you. So, for how many years injection denosumab is to be given, and do you need a break after denosumab? Is it useful or dangerous? You can classify on both.
Yeah, I think this question, probably because they're comparing with the IV bisphosphonate. Now, denosumab, we do have data of 10 years with the Freedom Extension trial, and the interesting finding was with the years of use, the increment in BMD and the reduction fracture risk was maintained. Unlike bisphosphonates, where there are some data showing that the benefit increases up to 3 to 4 years and then kind of plateaus. And also with denosumab, again, there has not been concerns of what you say, kind of excessive suppression or the increased risk of typical femur fractures, although very few cases are reported, but that's not a concern. We do have a definite evidence or a clinical trial data of using it for up to 10 years. Maybe we can even use beyond that. But what is important to know that when we are deciding to stop the therapy, it has to be for combined or followed by another another therapy like IV bisphosphonates. I think that is what is most important. Did I answer all the? I think there was a second part to the question.
Yeah. So post denosumab, if somebody asks that, okay, he has completed 10 years of denosumab, or he or she has cannot afford denosumab now. You have given it for 3 years. There has been an improvement in the BMD now. She wants that, okay. Uh, she wants to shift to bisphosphonate. Will you simply give a shot of zoledronate and stop there, or will you uh, and repeat it after 1 year, or will you have a separate approach for that?
As we know that there is a risk of rebound fractures, we have to kind of follow with an IV bisphosphonates like zoledronate. Of course, we have to kind of reassess and then start, but we have to start now. Although we know that bone formation therapies it is ideal to use it before starting anti-resorptive therapies, but even we can use it even after the anti-resorptive therapies. The benefits may be lesser as compared to starting it before, but there's no harm starting after the therapies.
The patient was less affording, so maybe if you
Yeah,
start
so
bisphosphonate.
yeah, if cost is a concern, and then probably we'll have to switch to
Yeah,
bisphosphonates.
and at times you find that the bone turnover markers or the cross labs keep on going up. So maybe 7th month post denosumab injection, you give zoledronate, and 2-3 months later, just because the response is not satisfactory, you may have to give a second shot. So I would like to know from Dr. Pavel that in this kind of sequential therapy, where you are replacing anti-resorptive by another anti-resorptive, the clinical tips to use bone turnover markers.
Okay, so I think that, let's say, the most typical situation is after denosumab, that 6 months after the last injection, we should start zoledronate, and I think it would be interesting to measure bone turnover markers, CTX1, 3 months later or 6 months later, and if we observe and if we find that CTX starts increasing and it's above the median in premenopausal women, it would be useful to repeat the zoledronate infusion. And in case of bisphosphonates, the approach would be similar, but the range time elapse would be much longer, because I think that if we have, let's say, zoledronate may be active for more than 1 year, even about 18 months. So I think that we can check bone CTX 1 year after zoledronate, and if it's very low, we can wait until 18 months, and if it's increases 6 months later, the next dose of zoledronate may be administered. Again, CTX1 is most useful because the increase of the CTX1 above the median in the premenopausal women is a good signal that bone turnover starts to increase and that we should do something to prevent the further increase in bone resorption and the further bone loss.
Yeah, I think very well taken point. I would like to welcome our other panelist for the day, Dr. Nitiraj Oberoi. Good evening, sir, and thank you for joining us for the day.
Yeah.
You are fixing a bone or watching the IPL?
No, actually, I'll tell you what. There is a huge family function, and I have about 50 people in my house right now. somehow managed a corner in the house, and I'm sat there and participating here. But thank you for having me over. Thank you, and it's a
Thank
pleasure
you,
to be
thank you. We are
here.
grateful to
Everybody.
you for joining. And let me start with a googly for you. So
Sure.
there is a question on denosumab use on avascular necrosis of the femoral neck. So do you use denosumab or you use zoledronate, and your practical tips about that?
Right. So, yeah. So, if you are in a stage where you are a fika RNA 2 on the femoral head, and we've seen a huge surge of femoral head AVNs post COVID. Um,
Yeah,
yes,
that's true.
we've stuck the conventional training of anti-resorptives to help recreate the scaffold. Very little experience as far as I'm concerned with denosumab. A lot of experience with zoledronate acid and with alendronates. Good results, uh, but very limited. Just a couple of cases recently where we have used denosumab in these patients. Not enough to give you an answer. But yes, with all the other anti-resorptives, good results up to FIC-ALA stage 2.
Oh. What do you monitor in a patient on avascular necrosis if the person is on bisphosphonate?
Um, See, monitoring as far as the bisphosphonates are concerned, or monitoring as far as recovery is concerned. So, as far as recovery is concerned, largely it is clinicals, and here's the crux. If you have any kind of subchondral fracture, we'd like to classify the subchondral fracture based on in a 360-degree arc, how much of the subchondral bone is involved. So if it is involving about half of the head of the femur, the subchondral area, the role of any kind of protectives is gone really, as is the role of decompression. So pretty much you're leaving him to an anti-resorptive and seeing how he behaves in terms of concentric collapse. So that is what we are monitoring. We are monitoring concentricity. And the way to monitor concentricity and extension of subchondral collapse is by doing a 6 monthly CT, or well, the 6 monthly CT really. Denosumab, bisphosphonates in AVN are not long-term stories. Therefore, monitoring as conventionally you guys do for long-term bisphosphonate does not really apply to AVN, as far as I know. So we essentially monitor recovery, which is pain and extension of subchondral fracture and concentricity. Three things we look for.
Thank you. Thank you for the valuable insights, sir. So the next question is how many days we get the best results in osteoporosis? I think it's not a game of days; it's a game of years. But I think we can get an idea about whether your treatment is working or not by looking at bone turnover markers. I would direct this question to Dr. Pavel, who can maybe guide us about how soon should we measure a bone turnover marker after starting an X therapy for osteoporosis.
Okay, so that depends on the medication and that depends on the marker. Let's take, for instance, when we start with denosumab, which has a very rapid effect on bone resorption. In fact, 1 week after the injection, the concentrations of bone resorption markers will be already very low. Now, if we use oral bisphosphonates, the decrease in bone turnover will be much slower. So if we use the markers of bone resorption, let's say CTX1, during the alendronate or risedronate treatment, I think that the first answer, valuable, will be after 3 months. And in case of P1NP, because the decrease in bone formation is slower, so we will find a decrease after about 5-6 months. Now, when it comes to the anabolic treatment, the increase in P1NP is very rapid, and practically after 2 weeks, 1 month, we can see already a valuable result of the increase. As I showed it, as I have shown for the algorithm, that the increase in P1NP will exceed 10 nanograms per milliliter. So when we want to have this answer, when, that depends on the medication, that depends on the marker.
Thank you for the crisp and pointed answer. I mean, maybe a very, very practical. I think conventionally we wait for few weeks, but I think an early measurement may also help, especially if the patient is apprehensive or if the patient has already had a fracture and we actually need to see whether whatever is given is working or not. Maybe very useful points. So the next question is to both Dr. Sahana and Dr. Oberoi, that person, say 75 to 80 years, has came with a vertebral fracture, and you have to advise whether you will use teriparatide or denosumab, and there's an additional underlined line there that the person's renal functions are normal. So will you be keen to advise teriparatide or denosumab?
Right. So, good question. Dr. Shetty, would you have first go at it, please?
Sure. So I think when we have patients presenting with vertebral fractures, what I do is I usually start with an anabolic therapy. So I will start with teriparatide, and then later, I mean, we give therapies for 2 years. So after 2 years, I would then switch on to a bisphosphonate or a denosumab. That's what usually I follow. But then we know that both the therapies would work well for these patients. But we are looking at long-term therapies for these patients. So in that case, I would always start with an anabolic, and then that followed by either bisphosphonates or denosumab. Of course, then there are patient factors also counts in. There are patients who do not want to take daily subcut injections. So I would also, I mean, we would give the option to the patients because both are effective therapies, and then based on patients' preferences, we can go for both therapies.
All right. So Joshi, how it feels with me is that and this is open to any kind of discussion, but I somehow feel that teriparatide has a better effect on the spine, and denosumab somehow has a better effect on the hip. So your question was fine. So yes, I would stick with teriparatide. I absolutely agree with Dr. Shetty. And then subsequently reassess and then shift over to anti-resorptives. But on the hip side, I don't know. This is something which I would like to open for discussion. But when we go back at the end of 2 years of denosumab, as now, it's been in my clinical practice now. This is, I think, 3rd or 4th year that we've been using denosumab. So when we go back and look back at the changes in the Ward's triangle, we find that the patients who've been on denosumab somehow improved that very rapidly, in a matter of 1 or 2 injections. Which is very encouraging in terms of propensity to get a fracture, and more so to be able to hold a reduction. So would you agree with the fact that if you're looking at, if you look at randomly bone density stories on the hip, we find that selectively there is, we are sitting in the -2.5 to -3.5 Ts on the hip. Would you be more inclined to be with denosumab or with teriparatide? As a surgeon, this is what I would like to know.
I would add 3 points over here. The most wisdom of jumbling the therapies and which to use have came from the house of, I would say, Felicia Coleman. So the first thing is, whenever you have a fracture, it's always better to use a bone anabolic. And the
True.
reason for that is the chances that the person fracture, the urgency is to go and heal the fracture, prevent the second. And the prevention of second fracture within first 2 years is better with teriparatide as compared to denosumab. Now, the second question is, when you use an anabolic followed by anti-resorptive and anti-resorptive followed by anabolic, the results are much better if an anabolic is followed by an anti-resorptive rather than anti-resorptive followed by an anabolic. So that becomes a pretty natural choice. However, someone who is 75 or 80 and coming up with a vertebral fracture, uh, my first thing, or maybe a standing advice for everyone, is to do a calcium and PTH. Primary hyperparathyroidism is not an unknown problem. So also malignancies which can come up with a vertebral fracture and hypercalcemia. And if you start teriparatide without checking a calcium, you are inviting a disaster. And lastly, if you look at bone density as a matrix of action of teriparatide and denosumab, the BMD may not always improve with teriparatide because it essentially forms a new bone, and a new bone may actually be forming in a blank area. So you may get a bone at an area where it is not there, and maybe I would have better explained it with a diagram. And so your gram per centimeter may not actually improve, but your
True.
P1NPs will definitely go up. The patient's fracture will definitely heal. The patient will definitely feel better, and the vertebral volume will go up, but the density may or may not. Whereas with
True.
denosumab, the volume of the vertebra may not increase, but the density will increase, and that's where the Ward's triangle theory comes, because that's an area where the turnovers are high, and denosumab helps. So if your BMD has not improved with teriparatide, I would always tell one thing, that teriparatide in India is an expensive therapy and also emotionally daily injections. Always do a PA1NP. You have a proof that you are giving something, and then that's working. Maybe on this interesting discussion, any concluding remarks again from Dr. Sahana?
Yeah, I definitely. I mean, that's what we usually follow. That we usually start with an anabolic therapy, especially for vertebral fractures, and we do see a very good improvement. And then, although literature-wise we do not see pain relief, but then clinically we do see a significant pain relief in patients when we start them on teriparatide. That's my clinical observations. The quality of life also improves. Versus that, like we have some patients where we offered teriparatide, but due to financial constraints, then we had to give this phosphonates. If you compare, I always feel that patients on teriparatide really do well. So I always give anabolic therapy for vertebral fractures if possible.
So I have a string of questions with me, so maybe let's have a little rapid fire. Indications and contraindications to teriparatide of this.
Yeah, I think you've already partly answered. If first thing is we have to always check a calcium, rule out primary hyperparathyroidism. So and then of course any malignancies, again we cannot use teriparatide. Indications, like I said, any patients with vertebral fractures, severe osteoporosis, we're looking for anabolic response. I think teriparatide is indicated.
Yeah, Dr. Pavel, there is a question for you. It's a partly a repetition, so I'll maybe little reframe the question. So somebody is being started on denosumab. Which bone turnover marker will you prefer, P1NP, cross-lapse, or both? And how soon should you monitor it after denosumab? Should it be at 1 week, 2 weeks, 6 weeks, or 12 weeks post denosumab?
But after the injection.
Yeah, which marker before and after, and how soon should you be monitoring it?
Clear. So if you want to monitor the effect of denosumab, the most rapid answer will be given by the bone resorption marker, for instance, by CTX1. And we will practically about 1 week after denosumab injection, CTX will decrease by about 70-80%. By contrast, P1NP will decrease after 3 months. So for the anti-resorptive medications, it is always better to use the bone resorption markers because we will have the answer much sooner. Obviously, as I said in my presentation, the main problem is that blood has to be collected in the fasting status in the morning. So in some cases, it may be impractical. It is much easier to monitor the treatment with P1NP because we can use the random blood sample, and the bone marker is much stable at room temperature. So from the practical point of view, it is much easier. However, when it comes to the anti-resorptive therapy, the answer we will obtain the answer much later. So if you want to have the rapid and reliable answer, bone resorption markers.
I think, thank you. Dr. Powell, I must say that you have added very, very crisp, important take home points which can be implemented next day in practice. Though tomorrow is Sunday, maybe from Monday we can start implementing this. Thank you. Thank you for the insights that you have given. There is a question regarding, can we give denosumab in diabetes? I don't find any reason not to give, but as a practical point, and I must say that I have not seen this happen, but I do monitor lipid profile because the packet insert says that there could be dyslipidemia that get worsens with denosumab. So maybe for satisfaction, I prefer to monitor lipid profile 1 month after starting denosumab. Dr. Sahana, any specific points for denosumab in diabetes?
No, again, I don't see any specific in the contraindications for denosumab in patients with diabetes. I think it is as similar. I think when it comes to therapy, most of the therapeutics in osteoporosis management, in terms of response, there is not much of a difference versus diabetic versus non-diabetic. It is only in treatment thresholds or the screening tools or the evaluation tools is what is different in diabetic versus non-diabetic. But therapies, I think there's not much of a difference.
Yeah, I think very important point. Dr. Oberoi, I have two important questions for you. So how soon denosumab should be given in patients undergoing THR or TKR?
Yes, very good question. There is enough and more evidence now which tells us that there is there's a change in the longevity in patients who've been osteoporotic, have undergone replacements, more so with TK, total knee replacements. So when we start our denosumab at 2 weeks, why? No answers. I think it's probably protocol. It's easier for us to follow up as the patient returns for the first follow-up at 2 weeks, that's when we remove the sutures, and that's when we start. As far as I understand, denosumab is not something like terminal therapy. You need to continue, and if you stop, you need to go on to antiresorptives. So 2 years is what we tell our patients, 4 or 5 doses, followed by, again, largely restricted by capability of follow-up and affordability. Denosumab is not as expensive as teriparatide, but it's not cheap either. So I think, yes, TKR patients, good evidence, early commencement, good subchondral reformations, good subchondral lattice formations. It's too early in the day to be able to comment whether there is a longevity change, but it's conjecture, and early starting is a good idea. For THR patients, I'm not aware of any such studies. If the other educated faculty here is, then they can please enlighten us. But I'm not aware of improvement in long-term survivalship of uncemented total hip replacements, or even uncemented hemiarthroplasties. Because what we are dealing largely with is hemiarthroplasties. Most patients with insufficient foot fracture hemiarthroplasties. So if you look at the femoral side of it, uncemented femoral limbs, longevity, I'm not aware of studies which have hinted, but total knees, yes.
Yeah, we discussed about diabetes and bone, Dr. Oberoi, and what we realized is that the bone density appears better in diabetes, and the bone actually is quite frail and disorganized, and that's what we are seeing on trabecular bone score. Now we think bone mentally, but you cut the bone physically. Do you concur with this? Answer?
Absolutely, absolutely. It's very interesting. You're absolutely spot on. Diabetics invariably, I think it's got to do with associated obesity. I don't know. I think an arthritic spine uh, with collapses somehow appear better on bone density studies. It could be very different on measurement of blood parameters. Paul can tell us more about it, Dr. Paul. If you could. But yes, diabetic patients, if you look at the very size of the sinusoids, when we are dealing with, because we are using minimal invasive fixation, the MIPO techniques, the minute you drill a hole in a metaphyseal or a juxta-articular fracture, the damn thing doesn't stop bleeding till you've stuffed a screw into it. So yes, you're right. There is the entire architectural bone uh, concentration is far less in diabetics as compared to normal people. But when you look at their scans, they are surprisingly spectacularly better than the others. I put the question back to ask as to why should it happen from a biochemical point of view. I haven't been able to explain this.
Yeah, so that's what was the second talk was about the diabetes and bone. So what happens is that the bone microarchitecture is distorted in diabetes, and what you exactly get is a BMD which apparently looks little better, but the bones are internally totally distorted. And so if you look at the microarchitectural modality like a trabecular bone score, you find that that's much worse in diabetes. So now maybe in Delhi in next couple of years you will have trabecular bone score, or maybe Max Hospital may already start adding trabecular bone score to the BMD, and you will get a better idea before you go in whether the bone is poor. But I think thanks for the hands-on insights. I have an interesting patient who wants to know from Dr. Powell that he is a CKD patient with I mean with a fracture, vertebral fracture. So are the bone turnover markers relevant for him, and which are the ones? And from Dr. Sahana, the patient wants to know that what should be the treatment. CKD means creatinine clearance is below 15 now.
Okay, so when it comes to the bone markers, obviously there is a problem with the bone markers because many of them are excreted by the kidneys or catabolized by the kidneys. So we have three options. It is bone alkaline phosphatase, intact trimeric P1NP, but not total P1NP. So it may be intact P1NP, which is